This is a presentation of the Texas A&M University capstone team assigned to MD Anderson. Our project is Surgical Oncology Intraoperative Time. In this presentation, we will briefly go over our problem definition, our methodology, and our conclusions and findings. Intraoperative time for us is defined as when the patient is wheeled in to the operating room up to the first incision. We were assigned with the task of examining all processes and delays taking place in this scope time and to provide recommendations for reducing waste and improving said processes.
To tackle a problem that MD Anderson provided, we examined each of the specific roles that happened in the operation room. This includes surgeon and anesthesiologist tasks, as well as tasks conducted by the nursing staff. Each of their tasks was broken down into a period of time in which they were recorded, and the amount of variation per task was also observed. We created a fishbone diagram that linked all of the tasks to show what factors affect the unstandardized intraoperative time. We also created a swim lane diagram to show that which tasks happen in tandem with each other and what result they have on other tasks that happen before or after them.
We performed our data analysis by using Pareto charts to identify the most frequent delay reasons. These were the top 10 delay reasons that would provide the most opportunity to reduce the average intraoperative time in our process. We compared the main building frequencies to the maze building, where they had an average intraoperative time of 23 minutes compared to 43 minutes, so that we can figure out why these delay reasons are happening more frequently in the main building than the maze.
So for some further analysis for each operation type, we broke them down into scope time distributions. And we can see that liver, sarcoma, and pancreas are typically the highest three, with the highest scope time distributions ranging from 45 to 55 minutes. So we can see, looking again at those same operations, patient last minute needs is again a very common culprit, but we can also see hospital emergency add-on, anesthesia consent, and nurse room setup occurring fairly frequently in those types as well. And so using these analysis, we can better help MD Anderson focus on the operation types and delays that might need more attention than the others.
The results from the data provided from MD Anderson showed that nursing room setups is one of the most frequent delay types that could also be improved in the future. Instrumentation delays was also a very frequent type that we personally observed happen multiple times per surgery. The results of our observations included findings in bottlenecking factors from CRNA duties and surgeon scheduling, as well as varied team composition when compared to the ACB operations. Moving forward, we recommended that scheduling routine nurse-doctor teams would help with both delay types found within the data provided by MD Anderson and would help with the efficiency between tasks that we observed from our own observations. Assigning a designated CRNA assistant would help reduce the bottlenecking factor from the CRNA's duties by performing tasks simultaneous to the CRNA. We also recommend a higher emphasis on recording accurate delay types in the future for MD Anderson to help reduce not only scope times that we're observing, but other scope times that they would want to cut down on in the future.